So a little bit of background on the Rural Healthcare Provider Transition Project, or RHPT. This is a project supported by the Health Resources and Service Administration and the Federal Office of Rural Health Policy. Janine Myers is the RHPT project officer. Then our purpose. RHPT is designed to help strengthen organizational foundation and the key elements of value-based care, including quality, patient experience, and safety of care. And our goal is to guide small rural hospitals and certified rural health clinics not currently participating in value-based care through advanced alternative payment models to prepare for and position their organizations to be effective participants in a health system focused on value. And now I'd like to welcome today's speaker. We have Ralph Llewellyn, CPA and partner at Eid Bailey. Ralph serves as Eid Bailey's partner in charge of critical access hospitals. For over 30 years, he's worked with rural providers, conducting operational assessments and enhancing financial and operational performance. Ralph is a frequent speaker at state, regional, and national events. He just gave a really great presentation with his colleagues last week at NRHA's annual conference. So thank you so much for speaking today, Ralph. We're really excited about what you have to share. I'm going to stop sharing and hand things off to you. Give me just one moment.
Thank you very much. Greatly appreciate the opportunity to visit on today's topic, rural health financial improvement through population health and community focus. I'll give a little bit of background here, and then we'll just jump into some content. My name is Ralph Llewellyn, and as she said, I'm the partner in charge of critical access hospitals with Eid Bailey. For over 30 years, I've been spending my time in rural health, first as a hospital CFO, and then on this side of the fence for about 28 years, working with rural providers around the country. Probably 95% of my time is in rural, mostly with hospitals, nursing homes. I'm a licensed nursing home administrator. We had clinics, a little bit of all that stuff you see in rural. In today's topic, the piece I've been with in population health for a while has been really, I got early on involvement in some of the rural ACOs. So think about, Caravan Health and things like that. There are a lot of things that were going on with the AIM funding. And so I've been a big fan of population health, and I get asked to speak a lot on that topic and how it really fits in the small rural setting. So today, the topic will be around that, but we're going to talk about how population health practices can be employed to help drive local volumes for current patients. We're going to talk about how it can increase value and market share and volumes, and then how this total cost of healthcare can decrease while local providers may actually see some increase in volumes and in revenues. That's the piece that usually has people confused and trying to chase down, why should they do this? So let's start by doing a little bit of a, what's the current status of the industry? So when we look at the industry as a whole, and this is, no matter where we're working across the country, each state's a little different. Each area of a state can be a little different. But what we're seeing at the end of the day is that volumes overall are dropping. And that's really been something that's happened since COVID. A lot of people exited, their normal patterns of getting health care, how often they went in for health care, things like that. We've seen some rebound in that area, but we haven't seen enough to say that it's come back to what it used to be. Still a lot of services that they're not getting the volumes that they used to get, not just in rural, but anywhere across the country. Then we're also seeing an increased challenge with payers. So, when you think about what we're seeing from the payers, you can't pick up hardly any article these days without hearing about the large increase in the amount of denials. Payment denials for services that have been rendered, payment denials for things that have already been approved, all kinds of denials. And the payers and the health systems are instituting more and more AI tools, a lot more expensive tools to find more ways to deny care, deny payment, things like that. So there's some pressure on the financials from that. Increases in the number of pre-authorization, the services that have to be pre-authorized. I thought pre-authorization was tough when I was a CFO back in the mid-90s. It's a piece of cake back then compared to what we're seeing today. More and more pre-authorizations and then denials even before you get the service. And then even just the payment levels. We saw substantial increases in costs through COVID. We continue to see that now with more changes in healthcare pricing. And the payment levels haven't historically kept up with that. We're seeing facilities that are having 5 and 10% increases in costs and getting 2 and 3% increases in reimbursement. Well, if you were already upside down, it just creates a bigger issue on every service that you run into as you're trying to build your volume and trying to build your financial picture. So with that, what we're seeing is a huge search for volumes. And so what we're seeing is we're working with providers across the country, and this is small, this is rural, this is big facilities. It doesn't really matter where you're at, but definitely in rurals that, there's this huge focus and this huge search to go and find new services. And, there's not a whole lot of new service lines to find, but there's a lot of time being spent there. Now, some of these can truly be positive if you can get them up and running. But with some of the challenges that we run into is that oftentimes they're also very costly. And if you don't have the financial infrastructure, you don't have a lot of reserves, things like that there, organizations just have a hard time getting up to the plate, being able to start that service, get it started, get it moving to a point where it can be sustainable. If they can get there, definitely there's the potential for it to be positive. But the other piece that they run into is that even if they figured out, if they build it, they can have some profit. Everybody's running into staffing problems. So they're looking to add staff lines in areas where they can't already find staff. And so the only place you're going to probably find staff is from existing service lines that might already be tapped as far as for resources, not having adequate resources. So there's this search for volumes that costly, maybe positive, but you really can't find the people. You can't find the staff. And so how's that going to work if you go down that path? And I'm not saying that people shouldn't look for new service lines, but just know that it's a challenge. It's not a piece of cake. It's not an easy track and path to get there. And then we look at population health, with all this happening, we're seeing people are struggling and trying to find volumes and everything else. And then comes in this piece of population health, and you hear people like myself and, some others on the call. I think Terry Hill's on the call. You hear us talking about population health and the importance of population health. And, so the question comes is why this fuss? Because I'm already struggling financially. I'm trying to find new volumes. I'm trying to figure out a way to do things better. And so now we get this huge push to reduce the overall cost when I'm already not getting enough money for what I need to do. So people will buy in that, we need a healthier population, but if we reduce costs, how's that going to work? So how do you sell this? And that's really kind of the importance of this presentation is, how do you sell the population concept? The concept of population health, when the goal appears to be lower costs and lower volumes, at a time that the rest of my organization and all the organizations around me are doing everything they can to figure out how to get higher payments, get higher volumes into the same market. So you feel like you're kind of tugging one way on one area and then you're pushing in another way in another area. So how do you pull that all together? So let's talk about, the volume proposition, and methodologies of how do you grow revenues if you're working with a facility. And, these are some of the first places I look, first is, methods for controlling growing revenues is collect for the work you're already doing. And what I mean by that is we have a lot of folks that are spending a lot of time chasing down new service lines, trying to build those things that maybe they can't find the staff for and everything else. And if they were able to do it, they might be able to drive some bottom line. But what we're finding because of all the denials, all the issues with pre-authorizations, all the things with the complexities of billing rules and regulations, which are continually changing, is that many organizations might be able to just improve their bottom line as much by figuring out how to collect for the things they've already are doing versus finding something else that they're going to bill for that they haven't quite got the processes in place to collect for. So think about that. That's saying go back to just figuring out how do I get paid for the things that I have. Spend my investments to shore up that process. That's one way. And for those facilities, which are not many, that have really shored up their revenue cycle, we see substantial improvements to the bottom line without doing any additional work. So you grow your revenue volume just by collecting what you've already done. You've already got the patients in the door, let's collect the cash. The next one is to add service lines. And we already talked about the challenges there. Now you're trying to find that patient or that staff that you can't already find for other departments. You're trying to figure out how you're going to build a new department. And the last one, which is the one I really like, and this comes back into a term that Terry Hill, and I'll talk about Terry a lot of times, probably in the conversation today. This goes back to leakage. Increase market share for current service lines. What we mean by there is how do you capture more of the volume in your community that's going somewhere else? And we do a lot of strategic financial operational assessment, market assessments, and things like that. And I'd say most facilities don't understand how much work is being lost in the market because they're going somewhere else. This is volume that you've already built the infrastructure to be able to provide the services. You just don't have enough people coming through the door for it because they're going somewhere else. And now they might be going somewhere else because of, not knowing you do the services, which is very common. That comes out a lot in community health needs assessments. They might be going somewhere else because of availability of hours. There might be because of reputation. There might be all kinds of reasons, but really at the end of the day, if you can increase that market share for cost for current service lines, you can start to drive some volume with maybe not so much incremental new expense. And that's where the real magic starts to come into it. And that's why I like population health, and I'll explain why as we continue on here. So collect for the work you're already doing. One of the things we find, if any of you attend things with Healthcare Financial Management Association, if you watch things with Becker's reports, you watch things coming out from NRHA, you're always hearing about facilities not getting paid for the things that they're doing. All the new AI, where you see people outsourcing a lot of rev cycle. Sometimes that works, sometimes it doesn't. But really, at the end of the day, what we're trying to get people to do is how do you set up your processes from the very beginning to the very end to collect for what you've done. And most of the time, it's focused around accountability. And what I mean by that is we have policies and procedures about what we're supposed to do, but they don't get done. And when they don't get done, we don't get paid. Things like at the front desk, do they collect all the current information, get the updated addresses, get the updated insurance cards, get the coverages, get all those things, do the pre-authorizations, all those pieces. Do we get our charges in on time? Do we document on time? Do we get the billing done the right way with the right revenue codes and the CPT codes and the dollar amounts and on the right forms, on the right licensure and all those things so we can get paid? And what we find in almost every rural provider we run into is there are multiple breakdowns in that process. And every time you have a breakdown, it's an additional cost to collect if you're ever going to collect. So there's a lot of opportunity there for facilities to just fix this area to drive some volume. Added services. Now we start looking at, okay, what are we looking at? And so providers, the first thing you got to do is you got to find the providers, the physicians or whoever else is going to provide that. What we're seeing is, and we're starting to see some movement in new areas. I'm seeing a lot more specialties added in. We're seeing a lot more infusion chemo. A lot of times we have some of that staff. If we're just doing infusion, we do. If it's chemo, now we're talking hoods, things like that there. So it gets it on into that capital cost. I'm seeing more discussion even in the critical access realm about cardiac cath. So we're seeing some organizations get into that, but that's got some expense. Radiation oncology, there's a few facilities that have added radiation oncology over the years, a couple more that are adding it now. Neurology and psych are probably a lot more common. Outpatient geriatric psych, that's another one that's not on this list. I'm seeing more and more conversation around that. Outpatient geriatric psych being a huge opportunity for reimbursement and things. But a lot of times what comes with that is huge capital cost, especially if you start getting into chemo with hoods, cardiac cath, radiation oncology. You're talking extremely expensive equipment and things that go with that. And then you got to find the staff around them, the nurses, the techs, whatever else is that you need, you got to find those. And in almost every market I'm in, they're telling me they can't find those people today for the current service offerings. So how do we find something else that's got a better potential to maybe drive some bottom line, at the same time taking care of the patients in the community? So increased market share for the current service line. So this is the discussing leakage. Almost every market we go into, we find substantial amount of leakage in the outpatient arena, mostly, including in the clinic also. So what leakage is there's volume in your community, but they're going somewhere else for some reason. So the volume is existing, but when we talk to a provider, they just find out that they're not capturing it. So what happens if we can increase the volumes by just doing more with the resources we already have? That's the big question. That's the big challenge. That's the big opportunity at the end of the day. So this is where I look at utilizing population health techniques to drive volume. And so the key concept is that you got to keep in mind that when we talk about population health and we talk about controlling cost, it's total cost, not the cost to just one facility, but it's the cost to the whole healthcare realm. So it includes all providers. So it includes those that are not in my town. It includes DME. It includes big pharma. It includes all of the pieces that I may or may not touch. And so while it does require cost reductions for all in totality, it does provide some opportunity for some. So at the end of the day, the key there, again, is its total cost. What is the total cost that's going to change? And that's the piece that I really need to be watching, is what's going to happen to total cost. So let's talk about things that you can use in population health. Annual wellness services, the annual wellness visit. And it's not a well-termed service because it sounds like a physical, but it's not really a physical. This is an amazing planning opportunity that a Medicare beneficiary and now more and more insurances allow reimbursement for on an annual basis. So what it does is it brings the patient in. It's really a planning visit. And then it's a planning visit from the aspect that it's sitting down and saying, okay, what's going on in your life? What are the things that are going on in your health? All of that there. What are the services that are out there that make sense for you to have in the next year? Let's get them planned. Let's get them scheduled. Let's make sure that we're proactively or preventatively doing as much as we can to make sure we keep you healthy rather than always just responding when something goes wrong. And so what happens is when you do these annual wellness visits, is a lot of time is spent by the non-physician, non-PA providers, non-NPs. A lot of it's spent by nursing gathering information. If it's done right, it takes a very little amount of time for the provider. It's mostly with the ancillary staff. But what this does is that it drives a large number of preventative services. And what I mean by that is that Medicare over the years has increased the number of preventative services that they covered. When I first started in healthcare, there was very little that was ever covered in a preventative service. To this day, an annual physical is not covered by Medicare. You have to have something else going on for those services to be covered. But there are a lot of preventative things. And the nice thing about those preventative services, these screenings and these other tests, is that most of them, not all of them, but many of them will have little or no out-of-pocket expense to the beneficiary. So while we're trying to get them in to do the right things, if they're Medicare age, Medicaid age, and the right payers, there may be no cost to them to have these services done. And why is that? It's because they're meant to be early detection. And so the more you do these things, the more you can detect things earlier. So now when you think about it, the preventative services, those are things that we can do. The more of those that we do, we get more volume. The earlier we find things, those are typically things that we might be able to do the interventions and help do the care to change whatever is not going right, whatever that health issue is. And so that's where you drive your local services. You get the annual wellness visit, you get one of those a year. You get the preventative services. Some of those are annually, some are every couple of years, some are every other year. It's going to vary. You always need to know your payers. the little out of pocket, think about it. Today I'm paying in for that for the future. Every time I get a paycheck, there's a little bit of money being taken out for Medicare. Well, that's to someday pay for my preventative services. No out of pockets. I've already paid the bill when I retire. Let's get the service. And we can think all ages because we're seeing more and more commercial payers chasing this down too. So there's a lot of different pieces there. Now, sometimes with the annual wellness visit, depending on the setting it's done in, for Medicare, if it's done along with another visit in the RHC, you don't get a separate payment for it. If you look at the annual wellness visit payment itself, some people say, well, it's an awful lot of time with staff and everything else for the amount of payment I'm receiving. Or sometimes people say my physicians are spending a lot of time on it. Well, that's probably a breakdown in the process because we can make that more efficient. But at the end of the day, a lot of people don't do it because they don't think there's enough payment in the annual wellness visit. And I think that that's sometimes where we're short-sighted. We got the blinders on a little bit because we're just looking at what happens on this one service. But when you bring patients in early and you start getting preventative services for them that are covered little or no cost, and you're doing early detection and you're finding things that you can take care of locally and you can make sure that they're maintaining or improving their health. It's all those extra services that help cover the cost of the time of the annual wellness visit. You got to look at it in the totality, the global amount. How much am I potentially looking at from a dollar and cent perspective in my local community that may never get spent, rather than wait until they have an accident health-wise or some healthcare emergency issue, whatever. And now we start putting them into air ambulances and we're shipping them out. We're sending them to places that do things that are a lot more extensive, a lot more costs, and we may or may not get them back. The other part is when you start doing early detection and you start having people finding out that things are being found early, it's a great PR piece. It's a good brand piece to say, hey, look at what we're finding, look at how we're helping people detect things earlier, how we're keeping them healthier. Let's help you too. Let's get people in the door. You can do that with chronic care management visits. There's all kinds of things you can use that are visits you can do that help promote a good brand awareness and get people in your front door. But this is a great population health technique that is being used better than it had been, but there's still a substantial amount of opportunity in the market to do better there. So again, transitional care, this is when the patient gets discharged. It's that first 30, 60 days of following them, making sure they don't get readmitted. So that's great quality care. Plus they're getting intervention, they're getting calls, you're checking on them. You start thinking about that, what that does from a brand loyalty when people are talking about, gee, I liked what I had for my service at the hospital. You know what? They continue to follow up. They're following up to making sure I'm not going to be readmitted. I'm getting the services I need, all that. Chronic care management, good volumes. The nice thing about chronic care management that some people don't realize is that really good chronic care management, we tend to see lower no-shows on clinic visits. We tend to see actually a little bit of an uptick in visits oftentimes because as the chronic care manager is working with the patient, they start to identify things early on. And they say, hey, you know what? You probably need to get in for a visit rather than ending up in the ER or something. Something's just not right. So it's really good from a brand volume, from a volume perspective, from a brand loyalty perspective. It's really, really good. The other thing I would think of here is, think of in-office versus emergency room or urgent care. The more things you can do to keep people in the office setting, I think is really important. And what I mean by that is access to the clinics. Too often, I think in our rural communities, we've got an 8 to 5 mentality for our clinics. And sometimes we need to think a little bit outside of that because a lot of our folks can't get there between 8 to 5 because they have work obligations, they got school obligations, they got whatever the obligations are of life, and they need something outside of it. And so what they end up doing is we think they end up in our emergency room, but that's not always where they end up because depending on where our next closest urgent care or our next closer clinic is or where our phone is, we can grab care somewhere else. And that's what they're doing. That's where we get a lot of leakages. They leave, and when they leave, wherever they go says, hey, I can take care of all these things for you. I'm available. I truly provide access. If we can expand our access a little bit as we're trying to do this population health, we can get those patients and those parents and kids after hours. Some people do it a little before hours, some do hours over lunch. It depends on what works in your community. You don't have to be open substantial hours, but you got to be open maybe a little different than 8 to 5. Maybe it's 8 to 6. I always say start a little and you can keep adding, but really try to build that and promote it. You can't just open it up and say, I'm now open and think people will show up. You really have to promote it, make sure they know about it. It's going to take a few months to really start to see that 5 to 6 open up. I have some that go to 5 to 7. Very rarely do I see them go anywhere beyond that. You don't have to go crazy with this, just enough to get them to come to you versus picking up some other alternative, either somewhere else in another community or by picking up that phone and using some sort of telehealth kind of option. So again, add this whole piece adds to local volume. And it's oftentimes things you already do, you just don't do enough volumes of it. You're already doing different screenings, you're doing different labs, excuse me, you're doing different imaging, you're doing all those things. You just could do a lot more with the same amount of staff. And it does decrease, if you do this right and you find these things early, it does decrease total cost. But where does it go? Inpatient, some of that will be local. So we're going to get might take a little hit there. Pharmaceuticals, the healthier we are, the better we manage our meds and things like that. There we see substantial reductions in the cost of total meds by just having good med management, med reconciliation, things like that. The earlier we find out things, we can reduce major procedures. Ambulance, you would not believe when we look at some of the cost data, how much is spent in air ambulance and in other ambulance because of health issues that come up that might have been otherwise preventable, as well as just emergency room. And so the goal here is we're trying to look at population health and looking at it from the rural settings. We're trying to move the costs from the back end of the healthcare model to the front end and near the front end. That's really the piece. And when I talk to big facilities and they ask me, who should be afraid of population health, if anybody, it should be the big facilities that have built things to, their process and their primary goal is to do high cost, high volume, things where they can highly profit. Our goal, excuse me, in population health is to prevent them from having to get there. So when you look at population health, you got 3 groups of providers. You got the local, provider. You got primary care. You got some specialty. We tend to do less invasive. We tend to be more proactive, more primary again, and lower cost. Those are all great things. If we can move more of that work to the front end, that's going to be positive. As we start getting into our larger or our competitors, excuse me, we're going to see primary care, specialty care, more invasive. Remember, they've built big brick and mortar. They got big ORs, big labs, big things going on. They need to push volumes of high cost things that happen when people are having health issues, health emergencies. They're more reactive, and they tend to have a high cost structure. And then we got the outside providers that really are neither one of, they're not really in the hospital, it's pharmacy. So this is looking at med management, it's the ambulance, looking at how do we control the amount of times people need ambulances because we're not catching something in time. It's very reactive, and again, it's a high cost. So how can we move that around? How can we get some of that cost to start shifting from one area to another? And that's really where the population health goes. And that's why people in rural settings should be excited about population health versus just being scared. So let's just look at the current spend. And this is just an example, so totally made up. So let's say in the current market, the local provider, is getting $25 out of every $100 that's being spent. The larger competitor hospitals are getting $40 because they're doing some of the high cost things. They're not seeing them as often, but boy, when they do, they get some big bucks. And then the other providers, pharmacy and all that other is getting 35 bucks. So at the end of the day, there's $100 being spent. When we look at population health, the goal in the rural setting is how do we take that $25 and by putting in annual wellness visits, and putting in chronic care management and all of these in preventative services stuff, we spend 35 bucks on the front end. And we take $10 out of that out of the large competitors because now they're not going to get as much big, highly invasive type things that drive big bottom lines for them. We're going to take $5 from the other providers. So there's another $30 that came out of there. At the end of the day, the total spend's now 95. In this scenario, population health works for you and the patient. When you think about it, patient should come out healthier. The total spend, $95, but you've got 10 more dollars. You got 35 instead of 25. That's the magic of pulling this all together. Now, when I give an example, it makes it sound like it's easy. And I'm not saying it's easy, but if you don't try and you don't take that run at it, it isn't going to happen. And so this is where the math, and I wish there were more examples like this, where people were looking at where does the money come from? The money can move to the front end. We're going to get more of that money because we're going to get more volume for the current volume that was going somewhere else. We're going to get more of the preventative for the people we already see. And what we're going to do is we're going to take some of that out of the other players, the larger competitor hospitals, the other providers, that total spend is going to still come down. That's the magic. So next steps, kind of where do you go with this? Where do you take this? How do you do something with this? And then we'll get into some Q&A. First and foremost, if you're looking to improve bottom line, excuse me, in the rural setting, first and foremost, you got to start collecting for the work you're already doing. I know that's not population health focused, but that there's so much opportunity just in collecting for the things that we already do, rather than finding something else we can't collect for. Then we look at service lines. What can we do in service lines, and what can we do to get increased market share for our current service lines, and that is, there's all kinds of things there. When people are trying to figure out how to increase market share, I tell them, go back and look at your community health needs assessments. You can actually add some things when you do your community health needs assessments every 3 years to really start asking people about when they don't come to you, where do they go and why? Is it access? You're not open the hours they need you. Well, then you got something you got to think about and start figuring out if you can do something different. Is it because they didn't know about your service? That's a very, very common item. I mentioned that earlier. Very, very common that comes up, that they just didn't even know you did it. We think everybody knows what we did because we maybe advertised it 5 years ago and we opened it, but they don't know it. And so they go somewhere else because they get referred or they heard somebody else went there. Is it a service line reputation? Is it a quality issue? Something like that. All of those are things that you would like to hear out of your community health needs assessment to help you better understand why people are going somewhere else. And then you can develop strategies and plans about how do I capture more of that just through awareness and everything else. That's just on the current service lines. And then you take that and you create this and implement this population health strategy. And you start getting people in sooner for preventative things, help them do the right things from a health perspective, help them get access to services they've already paid for in the past, especially in the situations of a Medicare beneficiary with all of those, that whole list of services that they can get, the screenings and preventative services at little to no cost. Those are great things to have. They're for the patient from a health perspective. They're great because we can do them for them. So create and implement that population health strategy to help drive the volume. So you've got multiple ways to drive volume, but really that population health component of it is a really important component of it. It really helps you drill down, how do you better provide care to the patients in your community? How do you address some of that leakage? How do you get a better bottom line? How do you put yourself in a better financial position to be there in the long run? So the strategy, how do you get this? Well, first of all, you have to educate your organization about the opportunities. Again, so many people just are afraid that reduced cost means I'm going to get paid less. And that might happen, but I haven't seen it in the market that I've been in. Everybody that I've worked with in heavy duty focus of preventative health and population health, most of them saw cost savings in the totality, but it didn't come from them. They actually saw or improvements or had stabilization. Inventory your current population health strategy and services. Maybe you have a couple things you do. Maybe you do a little bit of annual wellness visits. How do you get them to do more? I have some providers where 70, 80% of their Medicare beneficiaries get an annual wellness visit every year. They drive a lot of volume off of that needed volume and appropriate services. Now figure out which of those preventative services you already provide, which ones you might need to add. Um, where are your opportunities to expand and everything there? Learn the billing and coverage requirements. That kind of goes back to that whole thing. Make sure you can collect for the things that you're doing. We have a whole team that spends way too much time helping people trying to fix things that have been built incorrectly since the beginning of their service line. Make sure that you spend a little bit of time and effort and resources on the front end to collect that money. It doesn't do us any good to get patients through the door if we can't collect. It's just a cost, unfortunately, at that point in time. Re-educate your organization on all of this. Implement the updated strategy, report back on it. As you go through this kind of a process, you're going to find things work, some things don't work. That doesn't mean you throw the whole thing out. It just means you adjust. Adjust as appropriate, then come back, do the reporting, and continue to build on that process. But this is how population health can work in a rural community. But you gotta figure out where those dollars and those savings are, because until you can get the rest of the organization to understand that there is money in population health, it's gonna be an uphill battle. It's an uphill climb trying to get people in an organization and your board. Your board needs to understand this because they might be asking, why are we trying to reduce revenues? Because if we're reducing costs, that means I must be losing. You don't have to lose. There is opportunity to gain. So with that, I know that there was opened up to have questions in the Q&A, and I saw in the chat there were several reminders to keep putting some questions in there. So I don't know, Molly, how you want to proceed with that. Has somebody got some questions for me?
I have those. Yeah, Ralph, this is Rhonda Barkus. We do have questions.
Perfect. Thanks, Rhonda.
Yeah, so the first one is, and let me pause for a second and just say thank you again for this presentation, because I always enjoy when you speak, because you make things very practical, and I just really appreciate that a lot.
Thank
So
you.
the first question is, what are your thoughts and what are you seeing as far as an return on investment utilizing artificial intelligence tools for pre-registration and or prior authorization?
This is a really funny question, because we were just having a conversation earlier this morning um, for some of our educational planning for the next year for pushing out to providers and in the industry. And it was, the whole issue of AI. And so we're getting a lot of questions on that so far, just because everyone's talking about a lot of AI. In the small rural setting, we're not seeing a ton of that yet. So I'm not seeing people being able to get a good ROI on it yet, because of the fact that most of the time they're still gonna have to have one person there. Because as I think about it, the clinic I go to, I live in Fargo, North Dakota, so not a huge town, not a small town. Some will think it's huge, some will think it's small. When I go to my clinic, I used to go in and there would be I think six bays for admissions at the clinic. And so six bodies there. When I go today, there is one body, basically pointing and telling me which one to go over, and if I have a problem, come back and let them know and they'll help me. And so in that situation, they've been able to basically change things and get some decent ROI, because they've been able to redistribute 5 different staff people to something else at some other areas in their organization, or truly have a reduction in total staffing in their whole cost structure. We don't tend to see that in most of our rurals, because you have one admissions person or something like that. What I do like about it, and where I think we're going to see some potential return on an investment, is that the computer doesn't let you get past go without answering the question. And what I mean by that is when they ask for your address, you have to actually tell them your address. When they ask you for your insurance information, you got to give them the insurance information, or you can't click to the next spot. all of that data, the data credibility is going to be, and the integrity of that data is going to be so much better. So I think we're a little ways out before we're going to see a bunch of rural facilities doing it. So I'm not seeing much there. On coding, that's another one that I hear a lot of people using AI, and I'd say the jury is still out there. We hear some really good stories on that there where they feel like they're getting some really good return on their investment. But we've also, because we have a group that does a lot of reviews and compliance reviews and things like that, we've also found a lot of potential compliance components because the tools are only as good as they've been written and how well they've developed over time. And so I think that there is still there's still significant opportunity. I'm not saying it's not going to get there, but I would be really cautious if you're looking at it not just on the ROI that's being promised to you, but what are still the human interventions to make sure that the compliance and the quality is still there? I think that's what I'd have for an answer for that right now. In another year, there'll be a lot more conversation about more AI.
Okay, thank you. And then the next question, have you seen any nurse-led annual wellness visit models, and have they been successful?
So I would say, well, first of all, you got to make sure, depending on what setting you're on in, is a nurse-led one, meaning the nurse is the only one that's running it, if that's what they mean, that you'd be at risk of, is it even a covered visit? So you got to make sure you understand the setting. But I will say that one of the best models I saw early on was, and it took a while to get there, was a model that was built by a physician took the lead, along with some nursing and some other staff. And the whole goal was how are we going to build this to make sure it makes the most sense with the least amount of resources over time. And this was very early, actually, in the ACO caravan health, kind of that whole movement. And what they did is they really minimized the amount of time that the physician, PA, and NP were involved because they maximized their utilization of the nurse and in some aides and pharmacists and whatever else they needed to utilize. So I have seen that model, but it really had to be designed by a team effort because you got to make sure that you understand your processes, your layout of your organization. There's probably not a cookie cutter out there. So I have seen it where nursing is really taking the lead. But there's still an intervention or a component of the physician, the PA and the NP, and that can be extremely well laid out where everybody just is truly operating at the top of their licensure. RNs could be a great resource for that.
Okay. And the next question is, thanks, Ralph. If we reduced our overall out-migration by 10%, approximately how much added additional revenue might we realize in a year?
Wow, that's you're able to outdo your out migration by 10%. Well, let's think this out because I'm not going to be able to give you a dollar amount because everybody's going to be different. So let's say you had 60% out migration. So if you had 60% out migration, that means you're getting 40% of it. If you reduce that by 10%, so now you get it down to 54%, you're going to get 46% you're going to keep. So that's an increase of about 15%. That's just on that number. Now, obviously, if you were at 50-50, that's going to change a little bit, but that kind of gives you an idea of what's going to happen on those numbers.
Oh, thank you. Next question. What about better websites and community marketing and strategies to improve market share? I agree that most people don't know what services are available.
So, absolutely. So one of the things, when we do a lot of the assessments that we do, there's a couple of things that I recommend people to do is, first of all, do an inventory internally of what all the services that you provide. And then challenge yourself to go find if you can see that even shows up on your website. Now, it sounds like something simple, but you'd be amazed at how many things we find that people are doing that aren't on their website somewhere, even just in their normal list of services. And that really comes to light when we get community health needs assessments and people are saying, gee, I didn't know you did that. Well, if it's not on your website, you're not advertising, how would you know it? I also recommend people look at their website and compare it to some of their local competitors and then, their next big provider and see what they're advertising and the terminology they're using. Because as an example, if my father was not a computer user, but if he was, if he would have been on the website and he was looking and you said that you did chemotherapy, well, that's fine. He's looking for somebody who does cancer because that's the term he used. He doesn't understand the terminology. So sometimes we got to look at how many different ways do we say that what we do. If I was doing cancer care, I'd be advertising my chemo, I'd be doing cancer, I'd be talking about oncology, I'd be using every form of term because I need to get it to the right point, the right level to make it practical for the individual who's the reader, not for what I understand. And so we think about that in a lot of different areas. Infusion. My dad had no idea what infusions meant. He knew what an IV was. When you think about it, we use that word so interchangeably in the healthcare arena, but do we have that on our websites? You don't have to spend a ton of money on a website, but I think a little bit of money in that area to get that going. Some facilities have done a nice job of getting some outside resources, some professional resources to at least get them a nice layout for their website, and then they can monitor and maintain it. But you will never do too much work, I don't think, in advertising what's going on your website. And I like websites over like Facebook, because Facebook in 2 minutes it's gone. Because it's all of a sudden a lot further down the list of all the listings. I have a hard time finding things on facilities that use their Facebook as their kind of their media manager. It's just really hard to find services, hours, things like that there. Maybe somebody can make it look simpler and make it easy for somebody like me, but I find that difficult. Good websites are amazing. Bad websites are a liability. So great question. Definitely can do a lot more work in that arena. When I was a CFO, between me and about 3 or 4 others on our team, we spoke at the Lions, the Kiwanis. We took every one of those service organizations where there's a lunch when they were looking for speakers, we took advantage of the opportunity to just go and talk about what was going on in our organization. It may seem like it was everything that everybody should have already known, but it was news to them.
All right, thank you. We've got another question, and that is that from what you've described, the annual wellness visits have so much potential to impact the patient returning for other services. And I know with RIP that sometimes we hear that folks say that they find it hard to motivate potential patients to schedule a visit. Any suggestions on how to best do that?
Well, first and foremost, your physicians, your PAs, and your NPs have to be sold. Because if they're, in my opinion, if you're gonna get a patient to agree to come in and have an annual wellness visit, they're gonna listen to their provider. That's the person they trust. That's who they have the personal relationship with. If that personal provider brushes it off, the patient's gonna brush it off. In the markets that we see substantial engagement with annual wellness visits, it starts with the providers. So we need to start with them and help them understand why this is good. And and when you do that, you're going to find that not all providers are on board with population health because they only see it, they went to school to be in sick care, not in well care. And it's a different mindset for some, and they can't get past that piece of it. So we got to show them about how we can help them get more patients and better outcomes and all these other things which they should be happy for. And if we can get them converted, now they can be the champion because when the nurse says, "Hey, do you do this?" Annual wellness visit? No, no. Well, then the doc comes in and says, "Hey, have you ever thought about this?" Or the patient says, "The nurse always bothers me about doing an annual wellness visit. Why should I do that?" Well, here's the reasons why it's really good for you. I can tell you my provider, I'm not Medicare age yet, But I can tell you the provider I go to, I know he'll be mentioning an annual wellness visit every time when I'm there. Because he's always looking at those preventative things that we should be watching and monitoring to make sure that we're taking care of my health. And that's what you need. If my provider tells me I should be going and getting something, the probability of me doing it is much higher than anybody else in the organization.
Okay, all right. Thank you, Ralph. I appreciate that. And I don't see any more questions, so I'm going to pass it over to you, Molly.
Oops, trying to come off mute. Thanks, Rhonda. Thank you, Ralph, so much. This was a really great, informative presentation. We appreciate you speaking today. And thank you, everyone, for your participation in the Q&A. So afterward, we will be sending out the recording. You'll also see a link to a survey you can complete if you want 1 ACHE credit. You can also request a copy of the slides there too, so keep an eye out for a follow-up email. Otherwise, thank you all for participating today. Thank you, Ralph, for being our speaker. Reach out to the RIP team if you have any questions in the meantime, but have a great rest of your day.
Thank you.
Thank you.
Thanks. Thank you again, Ralph.
You bet.